Hello, I'm Andrew Zitzer. I'm the director of the Urban Strategy Graduate Program at Drexel. And I want to offer Harris Steinberg, our executive director of the Lindy Institute for Urban Innovation, also here at Drexel, the opportunity to just say a few words at the top of our conversation. So take it away, Harris.
Sure. Thank you, Andrew. And Priya, it's great to see you. I know how much
too.
pressure you're under, so thank you for all you're doing to kind of enrich our lives here at the virtual Lindy. Just a quick hello. Lindy Institute is going on 6 years old this November. We've got a range of programs and projects, but none more near and dear to my heart than the Masters of Urban Strategy program, which Andrew is the program director of. So I know Andrew's going to talk about that later, but I'm delighted that Priya is going to kind of share with us some of her thinking about urban strategy. She's one of the inaugural Urban Innovation Fellows, which we started the program, I guess it's 3 years ago now, which is incredible. But you've been a great kind of friend and supporter of the Institute, and we're delighted to have you here today. So with that, I will pass it back to Andrew, who I guess will introduce Priya. Thanks.
Thank you.
Thank you, Harris. Yeah, I want to just take a minute to introduce and properly set up Dr. Priya Mammen, who is our special guest today in this series that we call Urban Strategy in the Present Tense, which is an opportunity for us to showcase practitioners who think about urbanism in new, interesting, and generative ways. And this is the third in our series, and we expect to continue. In the past, we've had the other two Urban Innovation Fellows, Michael O'Brien and Christopher Spar. And the goal is to sort of link up the notion of an expansive view of urbanism with the work we're doing here at Drexel with the Lindy Institute and the Masters in Urban Strategy. So what will happen today is we'll have a conversation with Priya, and then we'll open it up for a little bit of Q&A. And then we will we'll close by me saying just a few words about the Urban Strategy Program and how that works so that you can spread the word amongst your networks about the work that we're doing here at Drexel. So without further ado, let me introduce Dr. Priya Mammen. After graduating from Tufts University with a Bachelor's of Science in Biology and Child Development, Priya Mammen has worked with John Snow Inc. and the U.S. Agency for International Development. She was engaged in health systems development in war-torn countries such as Cambodia, and specifically focused on the integration of reproductive health services to the community health infrastructure by facilitating interagency collaborations. Dr. Mammen completed a master's in public health at Johns Hopkins Bloomberg School of Public Health and her medical education at Temple University School of Medicine. She completed her residency training in emergency medicine at Temple University Hospital. Her research interests include emergency department utilization by the medically underserved and as a point of access to care. Interagency work has continued throughout her academic career. She facilitated ED-based public health initiatives such as safe opioid prescribing guidelines, overdose prevention, and HIV screening. Dr. Mammen's leadership and expertise are sought out. She was appointed to the Mayor's Task Force to combat the opioid epidemic in Philadelphia and named a fellow of the Lindy Institute for Urban Innovation. Dr. Mammen was further appointed as co-chair of the Community Advisory Board for the Department of Behavioral Health and Intellectual Disabilities and elected as chair for the section on public health at the College of Physicians. She served on the board of directors of Pathways to Housing PA and the board of advisors for the Villanova Law Institute to address commercial sexual exploitation. She is a trustee of the College of Physicians of Philadelphia. Dr. Mammen's career is marked by the consistent application of her experience and perspective as an emergency clinician to serve the well-being of her patients on the spectrum from individual to population health. And with that, welcome to you, Dr. Priya Mammen.
Thank you. Thank you so much for having me. And I have to say, it's one of my sort of most favorite affiliations that I have is with the Lindy Institute. I'm very proud of it, and I'm very kind of like the biggest cheerleader for the Lindy Institute.
Well, thank you, and we're certainly very proud to be associated with you as well. So let's get right into it.
Okay.
I want to just begin by asking you if you could tell us a little bit of your own story in terms of how you came to be a physician who's interested in broad issues of urbanism.
So, you know, I think one of the sort of lessons of my story is that it has in no way followed a simple straight line trajectory. I am the daughter of two physicians, and I certainly in high school and in college, was like, no way am I going to be a doctor, because that's what everybody wants me to be. And it's, to bring a bit of culture into to be an educated woman in South Asian descent, it's kind of like a given that you're going to be a doctor. And I was just all about like, no, there's plenty of other ways to have an impact. And so, but at the same time, I was still interested in wellness and health and those kinds of activities, probably just because it's all I knew. And so when I graduated from college, I started working in international public health consulting. So John Snow Incorporated is a non-governmental organization that runs programs, multinational programs, and local programs in the United States. But at the time, which was in the sort of mid-90s, there was a lot of international development work, and specifically around health and systems development that I was very interested in. So I started there, very entry level, basically like an administrative assistant. And kind of, the original program that I was working on was opportunities. It's called the Omni Project. It's opportunities for micronutrient interventions. And so what it was doing, this was the first time I had this exposure of having broad scale impact on health and wellness through integrations, through not just governmental processes, but private industry. And so this was a program that worked, if I recall, maybe like 23 different countries in Asia, Africa, and Latin America in particular. And, one of the examples is, it was based on people's diet. And so there was, and I'm going to forget the specifics, but I think it was Malawi, or maybe Mali, I believe, who did use a lot of grain products in their diet. And so, but also had iron deficiency, particularly in women and pregnant women, but also children. And so the work was to find a way to fortify wheat products with iron. And so it was, these things that was just built into how people lived, and the system was trying to figure out how to intervene in a way that was efficient, effective, and use different partners to get there. In about 8 months that I started, 8 or 9 months, I think a combination that I'm just kind of a doer, and my pace is sort of fast, and I'm like kind of impatient in general. I ended up getting what is basically a promotion, but I applied for a different position on the SEATS program. And the SEATS, as all things U.S. government, especially in USAID, everything has a fancy acronym, but SEATS was family planning, service expansion, and technical support. So it was more of a reproductive health program. And I was specifically responsible for, so it was still very administrative, but I was specifically responsible for the programs in Cambodia. So this again is now the mid-90s, and Cambodia was just coming out of a very horrific war-torn past. And so the bulk, I think, of what we in the US know and have heard is in the 70s and the late 60s, early 70s with the Vietnam War, but also the Pol Pot regime, which came in and was it's a communist regime that basically decimated the entire educated class first, and then predominant, kind of the workforce that was not agrarian and rural. So, and started in the cities, ironically, started specifically in Phnom Penh, which is the capital city. And so in that regard, it was a completely different approach to health, and it was reproductive health. It was focused on women at the time. There was like, I feel like 65-70% of the population were women, and the rest were men, and more than 50% of the population was less than 18. So it was just this world of different people dealing with different issues, and it had to be addressed on not this like, we're going to make the rice have the vitamins you need, but really have to figure out what was the decision making and what were the strategies with this very different population, and also in a war-torn environment. And it was during that where I sort of, again, my own frustration and sort of speed at which I was doing things. It's like I completely value this collaborative approach, because those are the kinds of things that it's government, it's private industry, it's the population, it's medical, it's nursing, it's all of the different disciplines had to work together to be able to create a system. And in this case, it was actually rebuilding a system. And our job, a health system, our job was to make sure reproductive health services were built into that. So along with all of the other aspects of medical and healthcare systems. But I recognized, I think, you know, the perspective that I was sort of kept jiving in with was really the direct care perspective. And I thought we would be going into villages and we would be doing different things, and all of the work we were doing was tremendous and would be effective probably in 10 to 15 years, right? We were building a system, and I would sort of see children, I would see women who were sick right then. I kept being like, what do we do? Like, is anyone going to help that person? And that was just not our space. And so I really went to medical school. I decided then to go to medical school just to gain skills and just to gain knowledge. But my intent was always to go back into the international world and work in that kind of collaborative process. Then in medical school, and, you know, the decision-making process, emergency medicine, both, you know, for the personality traits that it requires, as someone being fast thinking, someone being like just comfortable making strong and hard decisions, somebody who can kind of take in a lot of information and keep moving forward, you know, otherwise known as maybe ADD, but I have those traits. And so it fit me in that regard. In the other regard, it fit a lot of my missions in that it was the only part, emergency departments are the only part of the US healthcare system where it's really, there are no barriers to if you come. And particularly in urban environments, it also allows you access to people who may not have access in other parts of the system. So it fit kind of the full gamut for me. And then, you know, the reality is with life and aging and school loan debt, this idea that I have of going back into the development world straight away was put off by the fact that I had student loans, the fact that I had a baby, that I was newly married. I was married before the baby, but all of those things, it was like, okay, I'm here. But, you know, what I basically have done over the course of my career is taken all of the things that I really valued from those first experiences and brought it into medicine. And the way I've built my career around really trying to, again, you know, like I have a space and I have my skills as an emergency physician, but really in addition to that is my perspective of sort of using it as kind of a magnifying lens of issues that are affecting those, whether they're the most vulnerable or just the community around me. And it kind of then sort of allows me a pivot to look at a bigger space beyond just the individual, but to kind of get involved with whether it's policymaking or programmatic approaches to address some of the barriers that I've seen. And definitely not straight line. It sounds straight line the way I just said it, but it's very zigzagged.
Well, I think that's true for a lot of us. But one thing that I think is a theme that runs through it is a concern with place and space. You know, you spoke about the international work being defined by the problematic that that country or that city or that society was facing. And then moving into your work in the emergency department, there's a very specific spatial nexus where things kind of happen in the emergency department that don't happen quite the same way outside. And so I think it makes sense with the kind of approach that a lot of us take, that we're context driven and we think carefully about the places we find ourselves.
Yeah,
So
absolutely.
yeah, so I wonder if we could transition to talking a little bit about your work in the emergency departments and specifically how you became interested in the opioid crisis. That's how we met. What does the opioid crisis look like from the perspective of an ER physician?
So, I mean, I would say emergency physicians across the country were probably the first to recognize that there was a crisis building, and there was twin epidemics that were starting to happen, and that was both in the prescription opioid space, but also the illicit drug space and the overdose worlds that kind of overlapped them both. What we see is in the emergency department, what it started as from our vantage was more and different patients. So, what's unique about, there's many things that are unique about the emergency department, but one of the things that's very unique is that we are probably, especially in a city like Philadelphia, emergency departments are the interface between that community and that hospital system. Whereas if you were to look at surgical specialties, or you would look to any of the other medical specialties, there could be, especially in academic institutions, there could be patients coming from all over the world, right? I mean, they could be seeking out a specific specialist, or they could be coming from the suburbs and driving into the city specifically for their medical care, whereas that does not happen with emergency medicine. The ambulance laws that drive EMS systems is that they have to take people to the closest emergency department in a state of crisis. And if you are seeking out care and it is truly urgent in your mind, you go to the nearest place. So a lot of that is what we see may be very, very different from what the hospital sees or what people in their offices see that have other, I won't say barriers. In my mind, there are definitely barriers, but there are other processes to get in through that door. There is no specific process to get into the door. It's like at the emergency department in that you can just decide. But the picture of the opioid crisis started with increased need and usage of prescription pills and chronic pain issues or acute pain issues. And then it turned into overdose. And then it turned into trying to figure out how to help the people with overdose. So there's very few things where someone comes in literally dead that I will or any of my colleagues will fix in some way or bring them back to life, and then they walk out the door. Like in any other case, if someone has a heart attack, if someone has a gunshot wound, if it has any other thing that makes their heart stop and their breathing stop, there's no way that they're leaving if we bring them back, right? In this case, it's really the overdose reversals. Once you took care of that, somebody is completely back to normal. And in fact, about to go through withdrawal. So it forced me to understand the disease process of addiction and understand it in a different way, because they in fact are not well. They're just not dead. They haven't overdosed. But what the reality is that in the emergency department, in that moment, there's very little else we can offer them, because if we bring them into the hospital, there's not really, unless, it's not like a instant fix treatment. And so just the process of watching people come in dead and then leave. And I, would hand them a packet of information of here are drug treatment facilities and just felt so weak in what that was, and so helpless really in how to address what they needed. And honestly, as an ER doc, there's plenty of times that we're helpless on giant systems, but it's not often that I feel like I can do a lot more, but I actually can't because the system will let me, not because I don't know how to or I don't want to, and then that just made me see nobody else was seeing what we were seeing, because it's not like you go to your doctor's office in an overdose. It's not so it became we need to sort of raise the flag and be this is something that people are not aware of, and people who are prescribing opioids is one thing. People who are using opioids in other ways that are not prescribed, they were not being seen by the medical system at large until it was a full-fledged, just crisis. And we were dealing with high rates of mortality. And those are the kinds of things, that's the space that ER docs live in. All we care about is, not all, but the primary thing we care about is keeping people alive, right? And so when something has a high mortality, that touches us in a specific way that perhaps is a little bit more surreal to other types of physicians, like psychiatrists and treatment providers don't often see the people dead in front of them. And we were seeing that, and we were having those conversations with families, and we were doing what we could and realizing the system was really locked off to us, and therefore locked off to people who really needed them to be functional. So it was a sort of gradual learning process of my own frustration that kind of led me into more policy spaces. And again, started with the approach of just trying to understand different perspectives and try to be collaborative, to be more functional in the space I existed in.
So in the 3 years or so since you started thinking about this with the Lindy Institute, have you seen any changes in the policy infrastructure or in the practical treatment of people with overdose in the ED?
Absolutely. So in fairness, what my sort of time with Lindy was, after I'd already started a lot of the work, and when I was sort of coming to you, like, please teach me how to be better at this part. It's not necessarily the medical part, right. It's the engagement and sort of working out into the community part, right? And it was really, I think Lindy was the only place where I felt like you guys actually understood what I was saying when I was saying that, emergency departments are unique places, especially in an urban center. And Philadelphia is unique in and of itself just by the density of academic institutions. And each academic institution has at least 2 different emergency departments that work, and often more. But, each one of our hospitals had like an ED in a totally different community. And so what the opioid crisis showed us is what I was seeing in South Philadelphia was not at all what they were seeing in West Philadelphia at the same time, was not at all what they were seeing in North Philadelphia at the same time. We were all on a spectrum, but at very different places based on the communities that we existed in, right? And we were actually sharing a lot of that information and understanding because the bigger system didn't really get that. But Lindy got that, and that's where I was sort of coming to, like, I need to sort of see how this works in an urban specific perspective and understand from everybody else how we make these things kind of move forward. But I will say, in the 5 years that I've been really focused on the opioid crisis, I think the role and space of the emergency department has become undeniably important. And I think it took just the kind of being really in this city of Philadelphia among the champions that have changed aspects to addressing care needs and trying to be patient-centered. And instead of you come to us, it's like we're coming to you because we recognize you need help. I think everybody started realizing that it was really emergency physicians in all of the systems that were the biggest champions and the biggest proponents of saying the system has to change because it's not meeting people where they need us to be. And we kind of flipped the switch, and then the system started supporting it. So in different emergency departments, and one of the things that I've done in emergency departments is try and find or develop programs that will kind of reach people while they're kind of like a captive audience, say, right? But we were not getting any funding, we were not getting any support, we were not getting any of those kind of structural supports. And now, in fact, it just happened like a few months ago, where so much of the funding money, and there's a ton of funding money, but it was going to treatment side without the recognition that, like, to get to the treatment side, you often are either seen in the emergency department or in crisis at some point, right? It's now that, so a CDC grant through the Department of Public Health of Philly is going specifically to emergency departments to be able to make that system patient ready and, really nimble in trying to offer care services where they need to be. That's one example, but it's certainly, the system has, it's slowly but surely. I feel like every time we take a step, it's like, oh, there's a whole other set of regulations or a whole other set of barriers that it's just a sign of how our health system kind of developed. And we're so anchored in worlds that developed around evidence or perspectives or thoughts that are from 50 years ago, but does not at all reflect our current society, and certainly doesn't reflect the unique aspects of urban environments and urban populations.
Yeah, I think from an urban strategy perspective, it's often the case that multiple disciplines and multiple sectors intersect and don't always interface well. So in this case, we have, the medical establishment, we have the insurance establishment, we have public health, we have public safety, we have families and the infrastructure around, just the sociology of it. And there's just so much complexity to any of these systems. And then over the last year or 6 months, along comes COVID. And I wanted to ask you about what has changed for you as a practitioner in the time of COVID, including, I know that you've been treating in a different geography. So how has that changed your perspective? How are things different for you in this moment?
So when you reference my different geography, I had only ever been urban as a physician. I went to medical school at Temple. I trained in Philadelphia. I've worked in Philadelphia at different academic institutions. And a couple of years ago, I kind of had this, I don't know, like it was a traumatic kind of process, but I think one that most of us at some point go through different types of mini traumas of like, am I actually getting anything accomplished that I really want to? And is this, like, am I addressing my personal missions or values and things like that? So just as more of like a forced learning experience for myself, I decided to like try and be an ER doc in the exact opposite environment that I had always worked in. So I'm now an ER doc in like a tiny little, very rural hospital in Chester County. And it's in, like it's farmland town. It's mushroom farmers and there's canning manufacturing, like canned products manufacturing. And then, sort of very wealthy landowners and things like that. What I've seen is all of the things that I experience and that I have spoken about and I have kind of advocated for of urban emergency departments is in some ways just ultra highlighted in rural environments. The difference though is that it's not as community specific. It's sort of like a wide swath. And so I describe, like there's migrant workers all the way up to very old money farm owners, right? And everybody in between. And so what's, I think, like I said, in Philly, it's like, I know I'm like in South Philly and I know how South Philadelphians work. And I know like when they complain about just a mild stomach pain and they're very stoic, like something bad's about to happen, right? Whereas there's other parts of the city where it's like, like you just get to know your community. In this case, it's really like there's no necessarily common denominator, but the disparities are much, much more accentuated. And so the difference between access to care and the difference between even just like in terms of geographic proximity, like they drive like 10, 20 miles to go to the doctor. And that's something in Philly, it's be like you can get a cab ride or like a subway or something, so everything just the disparities that I've seen and the barriers that I've seen from the city are actually much harder in rural environments. And particularly when you're talking including a population of migrant workers or, like immigrant populations or first generation populations. It's a whole different sense of empowerment. And so particularly in the span of COVID, there's a lot of fear of accessing care just because, and I don't know who's really in front of me other than sort of their illness and what they need from me. But there's definitely what we saw even in the city, and a friend of mine did work around it, was under the new administration and in Philly, I think I honestly, I never thought about it until the new administration, but I think we function under this world of where we are a sanctuary city. And that changes very, very quickly. I mean, it's changed even in the 4 years of this administration, but it affects how we work because it affects how people come to us, right? In a very rural environment, it becomes a whole different thing. And so in a COVID kind of scenario where you're very concerned about health and wellness and mortality, but you're also concerned about spread of a disease and spread of infection throughout a community, that takes on a whole other meaning of how afraid people are to seek out care and how afraid people are to kind of ask for help. And it's been a tremendous experience. I had this, maybe like urban snob, like, oh, it's going to be so easy. They don't get shot out here the same way or things like that. It's a whole other, and we touch on an Amish community. So there's like another whole component of the kind of, it's mainly injuries from the Amish community that I had never seen before. But it's all comes down to when people ask for help. That's what emergency departments are. And so like we have the skills and tools and resources to provide certain kinds of medical help, but it also gives us a vantage and a perspective of recognizing what drives people's fears and concerns. And so much of that is actually much more a systems level than an individual level. And those are the things that I can't fix right then and there, but those are the things that I'm driven to try and at least inform based on what I'm seeing. Because again, the narrative is always that nobody sees what we see, but what we see is so telling of the situation and like the current situation at any moment.
Well, it's so profound to hear you talk about the inequality that exists in rural communities. I think when you explain it, it makes a lot of sense to us, but I think those of us who are based in cities sort of have a very urban-centric perspective and sort of see the rural as a place of lower density and like the lower density of problematic incidents. And of course, that's not the case, especially when we talk about the complexity of today's rural environment. So, knowing that you're an individual practitioner who's interested in systems change, you said to me in an earlier conversation, we are on the brink of entire systems failing. And some of us have wanted to see things get blown up in order to make new systems. So what do you mean by that? And what are some of the new systems maybe that you can envision from your vantage point?
The specific systems that I can say that I've wanted to blow up are all, like relative to me being a clinician and an emergency physician in particular. But, take the opioid crisis. One of the things that I never thought about, and I have the luxury as an ER doc, is I don't know how anybody's paying for anything when they come in front of me. It doesn't impact what I do or how I do it. It's just they need something and I'm there to figure out what they need and try and fix whatever is hurting them. One of the things that the opioid crisis showed me is just how completely separate the world of mental and behavioral health is, and addiction falls under that. And things like homelessness falls under that. And so it was just like I'm spoiled for many reasons, but I'm spoiled as an ER doc is usually if I feel like somebody needs something for their health and wellness, I can I can get it done somehow, right? I can finagle things, or I can access services, or I can do these things. That's one of our superpowers in the ER is like we actually are resourced in a very different way. But in the world of addiction, the world of mental health, the world of those things, it was a completely siloed system. And that is a system that honestly don't even know how far back it goes, but it's very insurance based. It's very payments based. It's like the payer side has decided based on certain data that this is a better way. And I think it probably could be a better way if you are, and forgive me if this is sort of derogatory, but if you're like, you live on the main line and you're super wealthy, like you can make your certain decisions and you can seek out care and you have this sort of whole pot. But if you are navigating the system, it is an impossibility to figure out. And I as a physician, you know, arguably among the most literate, health literate people in this world, and I couldn't figure it out. I could not understand all of the different processes. So that's an example of a system that just needs to be blown up. And it's very, if you look at the regulations and if you look at all of these different things that we have to go through for mental and behavioral health in particular, it is based, I mean, it is fundamentally stigmatized, and it is fundamentally like judged that mental and behavioral health is just, it's not the same as a physical ailment. And addiction is not a disease, but a choice process. And everybody with addiction has to be treated as if like nothing they say is true. And so you have all these other systems to be like, we're not going to trust you or believe you. So we have all these other things to make sure that, you know, if you're in this program, this is how you have to do it. And the only way to accomplish this treatment is through complete compliance. And that's based on perhaps evidence from the 60s and 70s. It is in no way reflective of the current standard of science and the research literature or what we understand, right? But it's based in these things, and to change those giant things that also, you know, specifically involves payers and like federal policy just takes so much time. When I say this, I feel like the systems, there's big giant systems on the verge of collapse. Is COVID has shown all of these like dark underbellies, right? What is my existence in terms of being an emergency physician and predominantly urban and more recently rural is that I see all of these disparities. I've seen what is, nobody can tell me that there's not racial injustice and complete biases built into the way either we force people to access care or the system is set up to serve them. Again, the system is the same, right? I mean, like, yes, hospitals are a little bit different now, but ultimately it comes down to Monday through Friday, 9 to 5. If you want to see your doctor, it's Monday to Friday, 9 to 5. But really the rest of our society doesn't function like that anymore, right? And the rest of like our reality now is like at a push of a button, we can get or do whatever we want to do, whatever time it is, right? That's how we function. That's not how the medical system functions. And it's these things of like, now you have a scenario in which none of us can work in our usual environment. And so we have to figure out how to make healthcare systems or health services accessible to people who are in lockdown or who are in like a COVID precaution kind of system. And it is the first time where it's like, we have to, and not the first time, but I would say like, this is outside of the ER, because I'm there for whoever shows up, right? Nobody has to make an appointment or do anything like prove that they can pay, nothing. But everybody else had those kind of like, you have to go through these steps before you get in front of the doctor. And now it's like, okay, we have to figure out how to get the doctor in front of people wherever they are, right? And, you know, a lot has changed, even like telehealth access for addiction service and things like that. Like the federal government was the first, SAMHSA and the DEA was the first to say, okay, we will allow telehealth. We will allow all of these regulations that have stood to be temporarily taken down so that we can make sure to continue services to people who really need it and will be even more stressed. And actually the state of Pennsylvania was the last of those to come. It was like the federal level, the city level on par, where everybody was waiting for Pennsylvania to get on board and be like, let us do these things because they need us to do it. And they are high risk, you know? So those are the kinds of things where it's like, we've had this sort of like real life laboratory of like, do we really actually need all those regulations? Do we really need like all of this structure that we've just had in place? Or can we actually meet the needs of our populace and our patients and all of the sort of healthcare needs in a way that is much more meaningful to the way life is now? And I think the question remains, how much are we going to sort of dial back once COVID concerns are, you know, less salient? And I would argue like now is the time where those of us who've been like, ah, this is not working, those of us have tried to sort of educate ourselves, arm ourselves, and create these networks of all of us thinking the same way. If things have to change, if we're going to make any improvements, it's like, I'm just time to pounce. I think, like now we're armed because we've been sort of doing it, but the system has never allowed it. And now it's sort of like, okay, will the system allow for these, like truly I no longer think of them as innovative, but in the setting that I'm talking about, which is a very slow to change kind of environment, this is when the innovative problem solvers really are just can be like step aside, because we've already thought this through, and this is what needs, and this is what we've seen, and this is how we're using the experiences of the last 8 months to really drive for change that will be sustainable.
Well, may it be so. I hope these changes will come to pass. There's so much on the line for so many people. We have about 10 minutes left for our conversation, and I wanted to give space to open it up for our attendees to ask any questions they may have. I have one question that I'm holding in reserve, but I'm going to wait. And if people want to either type it into the chat, or if they want to raise their hands, I'm going to turn to gallery view. Most people have their screens off, so you can just either raise your virtual hand, or you can just type something in the chat. I'll give you a minute to think. And the way you raise your virtual hand is you click on the bottom button in the toolbar that says reactions, and there's a little hand there, or a thumbs up or something like that that can be used.
I'm not so scary.
Zoom's different. Zoom takes a minute for people to get ready with their questions. All right, well, we're waiting. Okay, go ahead, Harris.
Priya, it's really interesting because I come from an architecture and planning background, but followed a very similar nonlinear career path that kind of brought me to where I am in terms of, because none of this was taught in graduate school, but understanding that the real power is in policy, right? And how you can inform it is kind of where the action is. So where do you see yourself going? What's the next step? You've gone rural for a while, but I can't imagine that's your last landing pad.
No, it's an interesting question. I think it's like my like $64,000 question right now. I'm in a period of being very kind of thoughtful, intentional, and trying to learn as much as I can. The truth is, being an ER doc is kind of like my superpower in that it's like a skill set, and I'm so fulfilled by it. But as I kind of age, it is a very physical job. And I find myself more and more wanting to kind of take the lessons there and move it into a bigger space. And so, where I have been, and I think it started when I reached out to Lindy and was one of the Innovation Fellows, but it has continued of where will change come from, and there is so much value and power by surrounding yourself by different kinds of thinkers, but also like similar thinkers of like where they want to go, and so the academic medical world was not that for me. I think I've seen that. So the question is like, where is it? And I don't, after watching the debate last night, it's like, oh my God, what's happened to where is government really going to be the problem solver? I don't, and this is a conversation we even started with Jeremy Nowak way back when. It's like, it's not going to come from government. I think it's not going to come from federal government anyway. And so I'm just watching lots of different people and trying to like learn from different people. It's also hard in a COVID kind of thing where now like my skills as an ER doc are actually very saliently needed. And that's where I'm happy to be. But to constantly work for where the change is going to come from and where my people are. That's, I think, my biggest kind of point of discovery now. I don't know where I can't say if it's going to, I don't think it's coming from academics. I'll say that. No offense, I'm speaking to a bunch of academics, but I think the skill set that you get from academics, and again, it's a different kind of academics, medical academics, and the rest of the world of academics is very different. But the skill set and the collaborations and the networks, and again, just finding like thinkers is kind of where I'm focused right now, and trying to figure out if it's going to be philanthropy, government, local government, or other kind of avenues that way.
Right. All right. Well, we will be watching.
Priya, 2 questions came in that we'll give you just a couple minutes to answer. The first question is from Grace, which is, how has working in the smaller and more rural ER taught you anything about how better to work in the urban ERs? Have you taken any lessons from the rural example?
How it's better to work in the urban ER?
How you could apply those lessons better in your urban work if you go back to the urban. Did you pick up anything in the rural, if I'm getting this right, Grace, that would be good transferable skills for you?
I mean, I think it's given me tremendous amount of kind of feeling grateful in the urban setting, how much we have at closer proximity and how many options we have, and how really just like a geographic proximity, but the kind of networks we have in terms of community level organization, and how, at least in Philly, again, I can only really speak to Philly, but there are so many touch points and intersections between the community level and at least like mid-government. It's not like everybody has an appointment with Kenny or anything like that, but there are these collaborations that happen among all of our big industries. And those in Philly, again, from my perspective, like the academic world, the medical world, the community world, individuals, and advocacy groups, we do all kind of swirl in the same diagrams. And so it becomes a little bit easier, I think, to either ask somebody or to learn from somebody, or to sort of take that perspective and to kind of make a step. In the rural environment, man, there's like so little that's the common denominator, again, because it can span like 20 miles, and what I find though is what would frustrate me in the city of this like one size fits all, and I would be like, it's not one size, like every neighborhood is totally different. You cannot dictate like this blanket statement. That's like exponentially true in a rural environment, because the one size fits all is maybe including undocumented immigrants, certainly including migrant workers, certainly including people who have, multi-generational homes where, this is saying in the COVID world of elderly with babies and everybody in between. And then you have, someone living on their family estate that has acres and acres and acres. It's like it's just, there's nothing that is the same. And so everything has to be an individual approach, or at least a population specific approach to begin with. But I find that there's even less people to kind of turn to, and the county government level is very different from the Philadelphia government level. So it's very hard to maneuver, I think, in the rural environment. So it makes me like, we're back in the city and I can talk to different things. I mean, a lot of my policy work is still all city, but I appreciate both for different reasons. I've learned a lot from both.
So we have time for one more question. I'm going to read Ariel's question. This takes us back to the urban area. Ariel's question is, how do you see policies changing for communities at risk with no technology access, especially in urban areas? And I can just say I've seen this firsthand with the education system, this lack of technology access as an impediment to urban primary and secondary education. So do you see any sort of correlation with some of the health when you talk about telehealth and dropping the requirements and the barriers to access? Can you think about any policies changing for communities with no technology access?
So I mean, I think many of us, there's a whole cohort of us that from the beginning, before COVID, when telehealth was becoming more of kind of a streamlined process, we kept saying this is just accentuating and exaggerating disparities because, you know, like here I am, I'm on my laptop and I have my cell phone next to me and like an iPad charging somewhere, but that is not the norm. But what telehealth was kind of pitching to was exactly that person. And it was also pitching to, you know, the people who are very used to like, I'm going to push this button and I'll get whatever I just want tomorrow. It'll show up at my door. It was that. But the question then was like, well, what does this mean then for everybody who doesn't have those kind of services, right? And it was very, and you know, I actually was on, it was a BPHL fest that was a couple weeks ago. I heard people specifically say this, like, well, that's not really the role of medicine and that's not really the role of health systems. And I would argue that it is. It's not necessarily that medical system or health systems to fix, but it is absolutely the medical system and the health systems to inform. And so here too is where like a certain thing starts and it's based on what is currently in existence. But what I think is these can be the drivers of change, and that needs to happen because there is no question there is disparities. There is no question that, you know, allowing access to care from the comfort of your home for somebody who is as wired as most of us, and I think everybody on this call probably is, compared to a mother who has 3 children and has a partner who is, you know, like working all the time, or she can't work because she has to care for these 3 children, making that woman get on a bus to go to see the doctor is a it's like beyond inconvenient. It's like almost like a punishment in certain, and then particularly in a COVID kind of environment, right? Whereas like it is now, to me, it's like, okay, so now health system, why don't you have a talk with Comcast? Or like the school district said, we're gonna make sure that all children of the Philadelphia school district has a specific kind of Comcast access. These are where these giant collaborations have to come together, and it has to be kind of civically motivated and civically minded, because there is existing disparities. There's no two ways about it. But if we're going to take these steps ahead, it has to be that these collaborations and these conversations happen. And it can't be like, oh, that's not really my job, somebody else will take care of that. It has to be that as we make these advances in different kinds of processes, whether it's technological or not, it has to be lockstep with all of the other parts of our urban existence. Otherwise it doesn't work. Otherwise, to me, it's just pointless.
Thank you for that, Priya. And I think that's a great segue for me to wrap us up and to talk for just a minute about the Urban Strategy Program. What you've been saying, Priya, is about the intersection of systems and the incumbent need for everybody who participates in any kind of urban or rural system that is riven with inequality and lack of access and disparate access, to start thinking interdisciplinarily and thinking about collaboration and thinking about, as you said, blowing up the systems in order to build new systems. And I'm very much enamored of the work that you do because of its systems approach that drills down to the level of the individual who needs care in the here and now. This thing that you said before of taking the dead and having them become alive again in front of you, but then what is the system that needs to be invoked in order to make that person whole and not just alive? And so I think there's just a lot of richness to what you're presenting. And so just to say a few words, you know, that is the kind of question we ask in the Urban Strategy Program. We're not always talking about public health or medicine, but we're talking about a suite of interdisciplinary, interlocking questions that include sociology, history, economics, public health, engineering, and more. We have a 2-year, 48-credit master's program at the university, at Drexel University. And we have an incredible cohort of students who go through and ask these questions. Some of them are here with us today, and basically take their own individual approach, like you as a practitioner coming out of population health and public health and international development, went through your own path to become an emergency physician. Our students are finding themselves coming out of the arts, coming out of real estate, coming out of transportation, coming out of hard sciences, and making a transition into the world of interdisciplinary urbanism with our guidance, with Harris and myself and others there to help them with this inquiry process. And if the conversation that we had today is interesting to you and you would want to come spend some nights taking classes here at Drexel with us over the course of 2 or 3 years, we're very open and flexible to working professionals, and we're very much geared towards people who are untraditional thinkers. It turns out that we're actually having a graduate open house at Drexel on Saturday, October 17th. I'm going to put that in the chat, and I'm going to put a link to the registration. Of course, it's a virtual open house. So here's the date, and here is the link. And you can feel free to pass this information to anyone in your network who, when you hear this conversation, you think urban strategy would be the right home for them, because this is the kind of approach that they have to the way that they see the world. And I'll also, as a last thing, just put my own email address in if anybody has questions about Drexel, the Urban Strategy Program, the Lindy Institute. I'm happy to share with you more as we go on. But with that, we're coming up against 5 o'clock. I want to thank everyone for joining us today. Please spread the word about these urban strategy in the present tense series. Be on the lookout for further iterations of this to come in the fall. And I want to extend just the heartiest thank you and congratulations to Dr. Priya Mammen for all of your amazing work and advocacy.
Thank you so much.
Thank you. All right.
Yeah,
It's
thanks
great
to both
see
of you.
everyone.
Great program.
Great event, and we'll see you all another time. All right. Be well and be safe.
Take care, everyone.